Inatusaidia nasi hata kama tunatoa certain portion.
NHIF has made it very easy. So if you are a member of NHIF, 2 sessions are free.
Kidney failure, by definition and by description, is a condition where the kidney function is or has failed in such a way that you need some form of support, especially when you are in late-stage kidney disease.
I've been on dialysis approximately 4 years now, 4 to 5 years. And the reason my kidneys collapsed is because my blood pressure was out of control.
Nilikuja ni kama nasikia ni kama niko na malaria na tumbo inaniuma. Nikienda hospitali nikapatikana niko na high blood pressure. Alafu wakaniweka kwa madawa. Nikakaa kama mwezi moja hivi ndio wakagundua niko na shida ya kidney problem.
Mimi nilipata hii shida ya kidneys last year but one. Last year dialysis ilikuwa inanipeleka mzuri. Kwa vile mwezi wa 4 waliniambia sasa kidneys zangu zimeamuka. Nikaambiwa nipumzike niwe nakuja clinic. Kurudi ndio waliniambia inaonekana sasa inaenda vile ilikuwa tena. Nikarudi tena kwa dialysis.
Patients who have got acute kidney injury or acute kidney failure are at risks of getting chronic kidney disease. And if you diagnose or identify them early and treat, then we would prevent these patients from getting into chronic kidney disease.
NHIF has made it very easy. So if you're a member of NHIF, 2 sessions are free.
NHIF inatusaidia nasi hata kama tunatoa certain portion.
Dialysis nafanya mara 2 kwa wiki, Monday na Thursday. Alafu kulipa watu wa NEF, cover ya NEF ndio inakuwa inanilipia. Mimi silipi cash.
NHIF has improved financial access to dialysis because NHIF pays 9,500. So many of the patients you are seeing here and who are members of NHIF are not paying.
One thing again we want to really appreciate the government is introducing the NHIF cover for the hemodialysis. It's actually a real plus because these are saved most of our patients because they're able to, the services are catered by NHIF, so all that the patient needs is the transport.
We are encouraging all our patients in Homa Bay County to have at least NHIF insurance cover, which only costs 500 shillings per month, which works out at a total of 6,000 per month for a family of 6 people. So we feel this is quite affordable.
Nilikadimitiwa hapa on 6th of February nikija kufanyia transplant. Shida ambayo nimekuwa nayo kwa muda wa miaka tangu nijue ni miaka 2. Huyu Dr. Ho akaniambia kwa sababu levels za creatinine zilikuwa juu sana na urea, akaniambia the best thing kufanya ni kuanza dialysis immediately. Daktari kwenye mimi nilikuwa nikienda dialysis wakatuambia kwamba hiyo mambo ya dialysis hiyo ni kama stop gap. Hiyo ni first aid. Kwa hivyo hiyo sio kupona. Hiyo ni kitu unafanywa dialysis as you organize for transplant.
Dialysis is the one just for supporting. But you know, definitive treatment is when you have a diagnosis has been made. If your kidney has failed, then actually you need a transplant. So the first step is to make a diagnosis. The second step is to support you until a definitive treatment is reached.
So mimi nikafanya nini? Nikatafuta donor. Tukaita mkutano wa familia, tukaongea na my brother mmoja ndiye akakubali atanipea figo.
Last year we did nearly 200 transplants in the country. Our transplants are successful. Patients don't need to go to India anymore. And I'm glad that we're having this discussion because I want to tell the Kenyan that they don't need to travel to India. We can do most of the transplants in this country, and our transplants are very successful. In Eldoret, we have Moi Teaching and Referral Hospital, which is a public institution doing transplant. In Nairobi, we have Kenyatta National Hospital as a public institution doing transplant, and the other ones are private.
10 years ago, Kenyatta National Hospital and the Novartis and other people came together to form or to join and make what is called the Interlife program. Interlife program is our brand of our transplant program at Kenyatta National Hospital. And for the last 10 years, 200 plus patients have been transplanted.
Tukaanzia Eldoret. Mimi wakati huo sikuwa nimejua Kenyatta wanafanya. Nilikuwa nimeambiwa at least niwe na 2.5 million. Kama to be on the safe side, at least niwe na 2.5 million ili transplant ifanyike vizuri. Nilijaribu nikafanya harambee, hata ingawa haikuraisi pesa mzuri kwa sababu iliraisi pesa kidogo tu. Nikaona hiyo pesa hata haingetosha kwenda kufanya transplant huko Eldoret. So nikaona afadhali Kenyatta. Wakati nimekuja hapa nikaambiwa hiyo kadi ya NHIF kama niko nayo na my brother ako nayo hapa itaweza kusimamia nini hayo matibabu.
At the Kenyatta National Hospital, the bare minimum you need is $500,000. And practically that's the money that NHIF actually will pay. So we are saying that if you have got between $500,000 and $750,000, you can get a kidney transplant at Kenyatta National Hospital.
Anybody, any citizen with a kidney disease already being supported, NHIF paying for dialysis, should eventually have a transplant so that their life can be prolonged.
Nika got transplanted on 13th February this year. So nimekuwa tangu wakati huo nimekuwa admitted, nimekuwa hapa na sina shida yoyote, sina maumivu, nimefurahia hiyo process vile imeenda. Yote hasa sana ile service yenye nimepatiwa hapa Kenyatta.
After the surgery, the patient comes to the ward, and they are normally very sensitive patients because after taking the immunosuppressant drugs, the immunity is very low. So these patients are very prone to infections. So we have to make wherever they are staying free of infections. We have to practice the infection control measures in very high level.
They are not required to eat any root tuber due to the high potassium levels in them, like the cassava, the groundnuts, anything that's from the root, they're not allowed to take. Chicken is good for them, fish is good for them when well prepared. Meat in small according to now that one is calculated by the nutritionist.
Kuna madawa huwa tunatumia. Madawa haya inahitaji kulipwa. Ingine ni ya bei kali, ingine ni mingi. Inasimamiwa na mtu binafsi.
Donor nilikuwa nimepata ni mandugu zangu. Shida ingine ni najua ukishafanya transplant kuna dawa yenye utatumia. Na hiyo dawa ni pesa mingi. Hiyo ndio bado tena imefanya nisifanye hiyo transplant.
But the challenge is never the transplant itself. The challenge has been maintaining the graft after transplantation, because the drugs that are used to manage or to keep the graft working can be expensive. And this has been a challenge to many patients. And this is where we would call upon NHIF to come up and try to subsidize for that cost.
And for many people in this region and Kenya, you have to look for a donor, and then we refer you to a special center that we have at the Kenyatta National Hospital.
There's a lot of people out there waiting to do a kidney transplant, but they do not have a donor. We again must thank the President for accenting to the Health Bill of 2017, which allows for disease donation.
We have the Health Services Act, which was recently passed. It has a section which defines how organs should come, but we need an actual act to regulate this.
We want to create a service called the Kenya Organ and Tissue Transplant Services that will coordinate all these activities. And one of the responsibilities of this service is to increase awareness about donation and to educate people on being donors.
The aim is to try to improve access for people who have got kidney disease. And we are talking not only about treatment, but all the way from prevention, detection, and management.
The 2012, I was going to Kenyatta. I find it cheaper to come here because it is service $250.
Just before the government introduced the services at the county headquarters level, actually what happened is we used to refer patients to either Kenyatta National Hospital or MTRH, and actually we used to lose most of our patients.
Kwanza nilienda Kisumu, baadaye nikaenda Kakamega, ndio niliwekewa catheter. Nilianza 2016 mwezi wa 7 na nilikuwa nafanya 1 week 2 times.
From 2016 up to now, I would say that the numbers have increased. Yes, and the patients are able to access the services within our county, within our hospital.
I want to take this opportunity to congratulate our President Uhuru Kenyatta for really making available hemodialysis units in all our county.
Everybody was going either to Kisumu, to Eldoret, or to Kenyatta National Hospital. For the patients, it was very expensive because it meant the cost of travel, the cost of the dialysis, and the cost of staying in those various places. In 2016, we received equipment from the national government under the Medical Equipment Managed Services. We received 5 dialysis machines, plus patient monitors and defibrillators.
Prior to 2015, majority of these patients, some of them could sadly die at home because of the proximity, because some of them had to travel all the way to Eldoret, some to Kenyatta, and that comes with cost.
This has really gone a long way in making major and huge impact on our people. Before, our people were going to Nairobi or Kisumu, and the cost of traveling was very high. And even maintenance of people when they're in Nairobi is very high. So since then, when this equipment came to us, we have seen a huge relief on our people.
We really appreciate the government for that, for bringing the services closer to the patient. Unlike when the patient needed to travel all the way for these services, they can now get them at the within the county.
But the more important thing me thinking that is that the patient now is with us here improving the health condition. When we receive the patient here, in very critical condition, and after begin dialysis and put all of the treatment that the patient needs, the patient improving, and we are very happy.
Right now, there's about 50 public dialysis units that are run by the government, and there's about 150 private dialysis units. And this has really gone a long way into providing access to dialysis in the whole country.
Biomedical officers or biomedical engineers are able to maintain the machines. So in terms of our work towards sustainability, we are somewhere. Our own engineers can now maintain the services, and therefore we don't feel threatened about sustaining this renal unit.
Tusherehekea juhudi muhimu kuimarisha afya bora Kenya. Faida ya bima ya afya. twasherekea juhudi muhimu kuimarisha afya bora.
About 5 years ago, the African Development Bank donated some money to the Kenyan government to set up an East African Kidney Institute, which was to cater for the educating personnel related to kidney diseases, and this would serve not only Kenya but also Uganda, Tanzania and Rwanda. So as we're speaking now, there's an East African Kidney Institute which is not only training doctors, but it's also training nurses and varied medical personnel that work in the kidney area, including dialysis.
We started off with one nephrology nurse who was coming from Kisumu at that time. But currently we trained a few nurses for the county. So right now we have 5 nephrology nurses, and we are hoping to train some more. We also trained doctors, we trained a laboratory technologist, we also trained somebody in pharmacy and a nutritionist as well. So right now we have a clinical officer who has been trained, who is manning the unit together with our nurses.
Having a renal unit was something that nobody had dreamed about. Why? Our level, as at the point of devolution, we were hardly above a health center. We were nowhere close to running a renal unit. So for me, the unit is a success story for us. This is a dream that has come true for Migori County.
(36 to 67% of all critically ill patients also suffer acute kidney injury, and 5 to 6% of all ICU patients suffer acute kidney injury. So there's need to train the primary health care providers, who these are the clinical officers who will be able to support the dialysis centers and renal centers with insertion of the emergency dialysis catheter and also the permanent dialysis catheters.
Like for us, we had to sponsor 2 or 3 of them to go for a special training at Kenyatta National Hospital, and he is back here inserting the catheters.
My role as a nephrology nurse is to handle patients with kidney problems or issues, and especially this is in terms of replacing the kidney function by putting patient on the hemodialysis machine. And so currently as a unit we have 5 qualified nephrology nurses. We are able to run the unit, but the number of patients with kidney problems is actually going up every other day. So we need more nephrology nurses to be trained so that we are able to handle the increasing number of patients.
We are also challenged now to train a nephrologist doctor, because as we speak we are using the services of the Cuban specialist. Another success story. So for us in Migori County, the fact that the government of Kenya got into collaboration, into partnership with Cuba to support counties, we have a story to tell in the doctor we have today. Through training, he's been able to train other staff.
The acute kidney failure is what perhaps people are used to. The one where patients are well and acutely now suffer kidney failure to require perhaps dialysis or otherwise. And this is mainly caused by volume problems like diarrhea, vomiting, blood loss, particularly after an accident, or some form of sickness, particularly say things like malaria or food poisoning. All those can cause acute kidney failure.
Severe malaria can cause kidney failure. The reason why it can cause kidney failure is if this patient has excessive fluid loss, whatever that will lead to reduced blood volume, that is a potential risk factor to cause kidney failure.
Mostly, we find that people think that kidney disease is only for adults, but in this case, we find that we have also young children.
A lot of these diseases that cause kidney failure are related to lifestyles. For example, diabetes. Watch your diet, avoid getting overweight, cut down on your carbohydrates, do regular exercises, do not smoke. That will go a long way into cutting down your risks.
The reason my kidneys collapsed is because my blood pressure was out of control.
Of course, with the upscale of the dialysis services, it resulted in increased awareness, which means increased screening and increased testing, and that is what leads to what appears to be the rising burden or increased prevalence of kidney disease.
We must go for screening. For example, I can ask you, how do you know you don't have kidney disease? You don't know, and you can't know unless you go for screening. And you might be having kidney disease as you're sitting there in front of me, and in 10 years' time, you might be on dialysis.
Niligojeka ugonjwa wa kidney ama wa figo pasipo kujua, kwa sababu mtu hasikiangi uchungu wala wakati mwingine hata dalili hata kidogo unaweza kuona physically.
The World Health Organization and indeed the International Society of Nephrology is working too much or overdrive to try to reduce deaths from kidney failure. And we have got this initiative of 0 death by 2025. And this initiative aims or works towards trying to prevent preventable deaths through acute